Hello everyone, my name is Atmaram. I'm an internal medicine resident at the Chicago Medical School, Rosalind Franklin Medical University at Northwestern Medicine, McHenry Hospital. Today we are going to talk about an interesting case of septic thrombophlebitis of inferior mesenteric vein that is an uncommon entity that can be seen as a complication of intra-abdominal infective or inflammatory processes such as acute diverticulitis, appendicitis, and pancreatitis to name a few. So our patient is a 63-year-old gentleman with no significant past medical history who presented to our hospital with a new onset rigors, nausea, recurrent non-biliary vomiting, generalized headache, and left upper extremity weakness and numbness. Physical examination was concerning for pronator drift and abnormal fine motor coordination in the left upper extremities. Obviously, the stroke workup was started and patient's MRI of the brain did reveal a small area of restricted diffusion in the right cerebral hemisphere consistent with acute stroke. The patient was admitted for acute stroke and initially the antibiotics were referred considering no clear source of infection and no features of meningitis on initial examination. However, things took a turn overnight and patient started having fever of 103 degree Fahrenheit with rigors. To align with that, next morning patient's blood cultures were growing gram-negative rods. When we reassessed the case and asked a few more questions, the patient endorsed having mild lower abdominal discomfort that has been ongoing for some time that he had attributed to being constipated. We performed a CT scan of the abdomen to look for the source of bacteremia. CT scan of the abdomen revealed findings consistent with acute diverticulitis involving distal descending and proximal sigmoid colon. Patient was started on empiric IV piperacillin tazobactam and blood cultures were repeated. To our surprise, patient continued to have fevers for next 5 days along with having persistently positive blood cultures. Initially, the blood cultures were positive for pen-sensitive Escherichia coli and Pseudomonas aeruginosa. However, later on, some of the blood cultures grew Enterobacter cloaca. Considering patient's persistent symptoms and persistent positive blood cultures, we performed a repeat CT scan of the abdomen to look for any abscess or any other complication, and to our surprise, we found inferior mesenteric vein thrombophlebitis. The finding can be appreciated in the CT scan that is present in this slide. With this, he was also noticed to have a small tiny pocket of air in inferior mesenteric vein that's also commonly seen in inferior mesenteric vein thrombophlebitis. Successive blood cultures continued to grow Enterobacter cloaca and sensitivity revealed that patient bacterial strain was resistant to piperacillin tazobactam, and that probably explains why he continued to have fever. The antibiotics were switched to meropenem and blood cultures were repeated. At the same time, we reviewed the literature and found the rarity of this case. We also discussed about trying anticoagulation as this was used in some of the cases as we reviewed in the literature. However, we reserved the anticoagulation for in case patient does not respond to antibiotic. Fortunately, patient achieved defervescence with antibiotic switch and successive blood cultures were negative. The patient was discharged on 4 weeks course of oral ciprofloxacin and metronidazole based on culture sensitivities. Outpatient follow-up at 10 days revealed no recurrence of symptoms. The purpose of discussing this case here to make internal medicine community aware about this rare complication of acute diverticulitis. Septic thrombophlebitis of inferior mesenteric vein is a rare but potentially fatal complication of acute diverticulitis with a mortality ranging anywhere between 11 to 32%. Fever and abdominal pain are the commonest symptoms. However, patient can present with constitutional symptoms such as fever, rigors, nausea, and vomiting as in our case. A high index of suspicion is required to diagnose this condition, and we advise to have a high index of suspicion in patients who are not responding to empiric antibiotic treatment and having persistent bacteremia despite antibiotic treatment. Contrast enhanced CT scan or MRI or color duplex sonography of abdominal veins can be used as a diagnostic model. We stress that prompt recognition and early treatment with antibiotics are crucial. Anticoagulation is again a debatable topic and should be reserved for extensive disease, propagating thrombosis or antibiotic non-responsive cases due to a bleeding risk. We advise antibiotic refractory cases should be dealt with trying anticoagulation and also consulting surgical opinion. Thank you so much for listening to this presentation. Thank you everyone.